Hey, Lisa Satin. It's funny when people put their pictures on, then I can feel like they're there. It's like,
yeah.
Hi, Julie.
I have Robin on mute.
Okay, here we go. Hi. Lots of technical difficulties this morning. Good morning. It's Robin Shapiro. I'm the board chair of the Washington State Health Advocacy Association, and you've tuned in for our weekly community conversations. This morning, we've been having some technical difficulties, so I appreciate you being patient with us this morning. Just a reminder, these calls are recorded and we will be making them available to the public. So if you do not want your video or your audio recorded, please put yourself on mute or delete your camera. For those who are available on the camera, it's great to see you. We look forward to these weekly times to be able to communicate with all of you. So before we get started on our program for this morning, we want to take a moment because silence is really not an option. George Floyd, 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 George Floyd. We have to take this time to recognize the multiple tragedies that have been going on with George Floyd's murder and all the inequities that have been really laid bare through COVID-19 and through the senseless violence that has been gripping our nation. We just want to take a moment to acknowledge that we as an organization condemn violence and the looting that has conflated the very important messages of inequity and social justice, and that we as an organization embrace the opportunity to talk about the inequities in our system that have been going on for 400 years, and that we stand with our brothers and sisters to fight for social justice. So I'd like to just take a moment of silence before we start our program. With that, I would like to welcome our speakers this morning, Dr. Dale Reisner, who is a WASHA board member and is the medical director of OBGYN Quality and Safety at Swedish Health Services, will first start off, as she always has been doing in our weekly conversations, giving us an update on COVID-19 and how our country and our state are responding. And then we will welcome Shawn D'Amelio, who is Director of Business Development at With a Little Help Home Care Agency. And she's also the president of the Washington State Home Care Association. With a Little Help and Shawn have been partner members of WASHA for many years, and we're very grateful that she's going to be talking with us today about caregiving and home care. So with that, I'd like to turn it over to Dale Reisner. Dale?
Yeah, good morning. I wanted to do something a little bit differently this morning. I will start with some numbers, but I know not everybody that is on these community calls are from Washington State or always working with clients in Washington State. So just to put this into perspective where we're at with COVID, as of basically the end of last week, some of this data is from Saturday. So in the world, there's over 6 million cases and 370,000 deaths. And in the US, we have confirmed cases of 1.8 million and 105,000 deaths. So we have about a third of the deaths in the world in our country. And our cases that are confirmed is less. So I don't think our mortality rate is necessarily higher, but it's less because we've had such limitations with testing. And if you've been on calls before, you've heard me say this before, and we still don't have enough tests for absolutely everybody to get tested who has even minor symptoms. So bit by bit, that's opening up, and you will probably see jumps in the number of positives as asymptomatic people get screened pre-surgery and pre-delivery for OB and things like that. And as in lots of the communities in Washington State now, elderly people can, if they have minor symptoms, can go get tested. So it is opening up. We'll see more positives. Washington State reported deaths from any cause. It is over 12,000. And one of the things that I wanted to talk about today is excess mortality. So there are X number of expected deaths per month, per year, per week, that is based on history, like last year and the year before, and kind of taking a general look at what we would expect depending on the type of the year. The time of the year, like spring or fall. And so we have always have kind of an expectation of how many people may die in the coming year. Our excess deaths are those numbers that are over that projected number. So I just wanted to explain excess deaths a little bit, and then to put COVID-19 into perspective with that. So we would imagine that a large number of the excess deaths are from COVID-19 because we didn't have that before and we don't have any immunity existing. And in fact, in Washington State, 82% of the excess deaths, we think there's over 1,000 excess deaths to date in our state, over what we were expecting, and about 82% of that is due to COVID-19. And you know that in our state, the elderly have been affected more, as is seen across the world, and the disadvantaged either by income or by race, ethnicity. Some of the disparities that already exist in healthcare are also being affected to a greater degree. It is interesting that COVID-19 is not responsible for all of the excess deaths. And you've heard me, if you've heard me before, say, if you need to go to the hospital, go to the hospital. It's quite safe. And what we feel is going on with the rest of the excess deaths are people who are either accessing care late in the process of whatever disease is going on, or some that are not coming in at all. So the usual types of things, heart attack, stroke, probably not established cancer care, because those folks have done a good job of staying in touch with their providers and they get what they need, and they've not been considered anything elective. So it's probably not that group so much. It may be new diagnoses of aggressive cancers, but it's probably more likely the hypertensive related and diabetic type related complications. So again, a message from here and from everyone you meet is, if you need to be seen, make sure you get seen. We do have a concern that kids are not getting their vaccinations, and we're hoping that people will get more comfortable, certainly before flu season, and get caught up on regular vaccines as well as flu then.
So Dale, can you just repeat, because I do think it bears repeating, that you believe that excess deaths not related to COVID, likely because people are delaying care for the whole country, is kind of how many?
Yeah, so the country, so I mentioned Washington State, we think most of it was from COVID.
Mhm.
Across the country, COVID is felt to be responsible for 74%. So that's 26% of the excess deaths are from people not getting the care they need or would normally get, either because of fear for coming in or other types of barriers for them to be seen. So, yeah. Yep. So it's important. That's a really important message, I think, that excess deaths in the country is over 100,000. And so when you see the COVID statistics, you can magnify that by about 26% for the excess deaths from other types of diseases. I think that as wider testing is available, we may see that more deaths are attributed to COVID. So it may not be exact, but that's the ballpark of where we are right now. So I don't know if there's any questions about that. All right. The one other thing I wanted to talk about was antibody testing. So do you want me to just launch ahead, Robin?
Yeah, go.
Okay, yeah. And I'm happy to, and I want to make sure that Shawn has loads of time and some questions at the end as well. So antibodies, we know that we won't have a vaccine for a while. And that while may be, if we're lucky, end of the year, beginning of next year, or could be longer. There's lots of work being done, and there are things that look promising, but all of the testing to make sure that they actually work has to be done yet. So we can't rely on that. And then people are saying, well, I think maybe I've had COVID-19. I personally think I had COVID-19 in early February. So maybe I want to get my antibody tested and see if I have some degree of immunity to getting it right now again. Or, maybe I've already had a mild disease. I've maybe been exposed to someone who had it and you had the sniffles, but never got tested. So amazingly, as I started looking into the amount of antibody testing, because I keep hearing like there's a new antibody test available, there's more antibody testing available for COVID-19 than for any other disease that we know of. This is IgG, so it's the longer lasting antibody. And one of the things that's been discovered is that you really need to test after 3 weeks. So if somebody really has been acutely ill, at least 3 weeks into the disease. With the antibody, the IgG, the longer lasting one is the one that might protect us, or at least if we got infected, make it be a little less severe in the future. We don't know, even those with, we do not know how long or how well those would protect. So just that's a lot of unknowns about antibodies. There are now over 200 products available to test antibodies. And some of them have been as poor as 50% ability to reliably detect antibodies positive. And we call that sensitivity. So the ability to test for a disease and know that it's there, a true positive is the sensitivity, and a true negative is the specificity. And so ideally you want a test that is high for both. It doesn't usually work out that way. Usually one, either sensitivity or specificity is a little higher. There are some products right now that look quite promising. And there are, for every one of these that gets made, there are places like Mayo Clinic and some other sites around the country that are actually doing testing to look for the true sensitivity for positive.
So clarifying question, Dale, from Beth Barnett. So the antibody testing should be tested 3 weeks after first symptom, or 3 weeks after full course of the disease?
It should be 3 weeks after first symptom or after positive test.
Okay.
Right? So if somebody was tested, so if I was sick in February, if I have, maybe I made antibody and it's gone, or maybe I still have some, it would be interesting for me to know that. What would I do with that information is a whole nother story. I did want to note that in Spain, who's, a little bit ahead of the US in terms of the whole process of the disease. Obviously, Spain is about the size of one of our states. But they have been doing antibody testing with one of the more reliable tests. And they found that only about 5% are positive for the IgG for COVID-19, which means there's no herd immunity out there. You may have heard me talk about herd immunity before, that many people, because of the way we've isolated ourselves, I would say, have not been exposed to that disease. And there's probably far fewer asymptomatic positives running around than what was suspected. And we're figuring this out as we do more universal testing on patients that are coming in for elective surgeries and things like that.
And I'm going to slow you down because you're talking quickly. So so there's a lot of information kind of going along, but one of the things that you just said is that there's likely lower number of asymptomatic COVID positive people out there. That's what I heard you say.
Correct.
Which means that people that don't have symptoms but do have COVID, fewer than thought?
Yes, originally people were suggesting there might be 20% of the population that had COVID, could pass it along and had no symptoms. That is not what we're seeing as we are able to more broadly test people that have no symptoms. And so that is good.
Yeah.
But it also means that the disease has been symptomatic, and the severity of the symptoms are not helpful. So
yeah. So, and a related question to that is, this is from Carrie, and then we'll get to Shawn here shortly, is don't we have to have at least 80% antibody immunity for it to be effective as a population? And that's what you were talking about in terms of herd immunity.
Correct.
So we're nowhere, if we're only 5% or.
Yeah, so that's Spain as an example, but I am imagining it's not going to be a whole lot different as other countries that have, a few steps ahead start looking at this. I think we're going to find the same kind of situation. So we can't on that. Yeah.
So this is going to be with us for a while is the bottom line. Even though we're tired of it and we don't want to be talking about it or dealing with it, but too bad it's in our face. Somebody just wanted to also ask about the COVID-19 positive cases in King County, since we're not able to go to phase 2 yet. And I don't think we chatted about that because a few weeks back, we thought that we would be in better shape, I think, than we currently are.
Yeah. And I didn't pull the King County numbers, but we have had continued cases. It's been relatively stable. We are really concerned that as Robin started this meeting with all that is going on around the George Floyd death, as well as the, as she noted, one of many, and the big gatherings that have been happening with angry people shouting and being in close proximity to each other, that we will get some flares of that. So I think King County in particular, we need to watch for that. And other cities that have not been as well managed as we, Chicago had big numbers out as well, and they are not quite as far ahead as we are in terms of their case occurrence. So we just need to keep an eye on that. Yeah.
I was trying to pull up the numbers, but I don't have them at my fingertips.
Yeah, it's been fairly steady.
Like 50 new cases or so a day, I think.
15, 14, 15, sometimes 10, but yeah, not close enough to zero yet.
Yeah. Thank you for that update. And I want to make sure that we have plenty of time to get to the topic at hand with Shawn D'Amelio. So Shawn?
Hi.
Hi.
Good morning.
Great to have you here.
Yeah, thank you, Del. Yeah, the antibody piece is always interesting, especially in home care. That's one of the pieces that everybody's very interested in right now.
Yeah.
And not knowing if you have it, will it really prevent you from getting it again? Although I know, Del, you and I kind of briefly talked about that yesterday, saying that most likely there's something that's going to prevent you from getting it again if you do have the antibiotics.
Yeah. Yeah. Most antibodies against viruses actually do confer some protection. It's just how much is the question. So.
Right. Well, hello, everybody, and thank you so much, and especially for those of you who have your videos on, because it makes me feel like I'm not speaking to the black hole. Really appreciate that. And I have to give a shout out, like, Steve, your beard. You have a beard. You have a COVID beard, and I love it. And it's great to see you. So thank you for having me, first of all, Rabbi. I really appreciate it. I really have appreciated all the education you've been providing through WASHA. It's been wonderful. I decided that the first thing I wanted to talk about was the difference between home care and home health, because I always find there's a lot of confusion between home care and home health on an ongoing basis. Even with healthcare providers, there's some confusion with home care and home health. So I just wanted to talk about first what kind of services home care provides and where they can provide it. Home care can provide companionship, respite for families, meal preparation, grocery shopping and errands, medication reminders. Although we cannot dose medication, we can give medication reminders, support for services for chronic conditions, nurse delegated care. That's things like putting eye drops in your eyes. That all has to be nurse delegated. Personal care, bathing and dressing, toileting and incontinence care, assistance with exercise, light housekeeping, pet walking, transportation. Those are the kind of things that we can provide care, home care can provide. And we can provide those things anywhere someone lives, whether it's a private residence, independent living, assisted living, memory care, or an adult family home. We have been known to go into hospitals when people have been hospitalized, but obviously that's off the table right now with COVID. It's off the table for us to go into skilled nursing. And right now, even with independent living and assisted livings, only some are letting us in. So it's been really challenging because home care as a whole, we'll go into that a little bit later, but has taken quite the dive in their number of hours of care that they're providing due to the fact that they can't get into some of the communities that they provided it in. Home care is typically ordered, is not physician ordered, sorry, and it is covered by private pay. If you need assistance with ADLs, it can be covered by long-term care insurance, veteran benefits, or Medicaid.
And I just want to jump in here. ADLs are activities of daily living, and most people know that, but.
Yes, and those include eating, bathing, dressing, toileting, transferring. Any of those things that you need help with, those can be covered by some of those other insurances or Medicaid. Then the other piece of home care that I like to address is when you are thinking about bringing in home care, that you're really considering hiring a company that is a licensed company through the state of Washington. And right now there are currently 250 home care companies in the state of Washington, 220 home health care companies, and 35 hospice companies, sorry. So the reason I think it's important is because when you are hiring a licensed home care company, they are licensed and bonded. They perform background checks. They require fingerprinting. They conduct formal training. They have backup caregivers if your caregiver is sick. They have supervision and support for caregivers. So I can't undervalue that one point right there, because even when we were down on the Hill lobbying this year, one of the points that was made is that some of the independent caregivers did not have anybody to go to. when they were having challenges, they didn't have the kind of education or support that a home care company provides. So then they were left in scary situations. They felt vulnerable. They felt vulnerable for themselves and for their jobs. And it makes a big difference when there is support for caregivers. Home care companies pay the payroll taxes, they provide benefits, they ensure workmen's compensation. And the thing I think that we want to really avoid the most is making somebody an accidental employer at the time when they are most vulnerable. I think that's an important thing to take into consideration. And then when it comes to home health, the services that home health provides are physical therapy, occupational therapy, speech therapy, a visiting nurse. And a visiting nurse can take care of wound care. If you get a new diagnosis, they can do education around that. They can set you up with a new medication regimen. They can do ostomy and colostomy care. They collaborate with IV infusion nurses, and they have social workers that can be on board, and they have home health aid to assist with bathing. But home health is physician ordered. And right now an ANRP can also order home health. And I made myself a little note here because I didn't want to forget to mention this, but the Medicare and healthcare authorities recently issued waivers to allow PAs to order home health, which is a really good thing. I think I'm hoping some of these things, like many of the things that we've kind of brought on as COVID related, are going to stick after COVID, because these, from my perspective, that's a really good waiver.
So, and I have a comment from Lisa Casaro, who said insurance may cover if you need assistance with 3 ADLs. Insurance might cover a caregiver, and that has to be supported by medical documentation. Is a question.
Yes, that's
Yes.
true.
Mm-hmm. And Medicare does cover home health care. So just people are kind of piping in on that.
Home health, but not home care yet. It is on the docket, but not yet. So the thing about home health as well is that there has to be a skilled need for a nurse or physical therapy. So that's one of the requirements. The patient, it has to be homebound, meaning it's difficult for them to leave the home unassisted. They may still leave for medical appointments and necessities. And the doctor or ANRP has to order has to order home health. So I hope that's helpful in defining that. The other piece is that home health, I feel like home health is often underutilized because it is fully covered by Medicare. And as long as there is a need, the service is covered. So while there's typically 12 to 13 visits, if the need is continuing and you still are progressing forward, they will continue to reorder home health. And I think that so many people don't take advantage of that home health because they're going home from the hospital. And this is what I see often, is that they're going home from the hospital and we'll say, would you like to have home care? And they'll say they've already got home care when they're actually going home with home health, and they don't understand the difference. So there is a big disconnect there. And I think it's important that we're really understanding, if we can get home care home with home health, the benefit to that is lower readmissions back to the hospital, in my opinion.
Yeah. So can you help us focus right now on maybe some stats of how many non-family caregivers there are, and just kind of get us oriented to how big of a an industry this is, and how with COVID-19, there's probably been a lot of barriers, as you were talking about. So what's happening to all the people that need external caregivers to come in? Tell us.
Well,
it's
it's been
what's happening.
Yeah, it's been challenging because, like I mentioned, there are 250 home care companies in the state of Washington. I can't give you a number of how many caregivers there actually are. I don't know that number off the top of my head, but I will tell you that there were the first 2 to 3 weeks of the COVID starting, home care companies took a big dive. I know we took about a 30% dive in our hours because clients didn't want our caregivers coming in, or caregivers were afraid to go in. They didn't want to expose themselves or their families. So it took a while for that to start sifting out and getting to a place where people were finding the new normal, per se. It also had to do with how well were companies communicating about what we were going to do to protect somebody. For instance, I would say I can't imagine that there's any home care companies that are not now doing symptom checks prior to every single shift. They are doing client.
And is that also client and caregiver?
Yes, well, we have requested that of clients, that if they are showing any symptoms, that they are communicating that with us so that we can then go back to the caregiver and say, we have a client who's demonstrating symptoms. Are you still willing to go if there's still care needed? And then if a client or if a caregiver has been exposed to somebody that has COVID, then they've gone into self-quarantine for 14 days. So there's a variety of challenging things. For home care, one of the bigger problems that is now starting to resolve itself was PPE. Typically, home care doesn't provide PPE to their caregivers. If they're providing assistance with toileting, usually the client provides gloves for that. So past that, we don't have masks. So it's been really challenging.
Has that changed?
That absolutely has
Okay.
changed. Every caregiver going into homes are wearing masks at this point.
And is that something that's generally provided by the home care employer, or is it up to every, like, how is that, how does that work? And we also have another question about universal precautions. Like, are there any universal precautions that everybody
Right, yeah,
adheres to?
that's the great thing about our caregivers. In-home caregivers are all trained in universal precautions. So yes, is the answer to that.
And tell us what that is for people that don't know what universal
course
precautions are. Yeah.
Washing your hands. Of course you're going to ask me that, and I'm like going to be like, okay, come on, Dale, what are those again? Washing your hands is a huge one.
Yeah.
Taking out, not wearing gloves from one room to another, using safe precaution, taking off, you're not spreading the germs between patients or rooms, basically, right?
Yeah, great.
And then, you asked me one other question, Robin, I wanted to address. Can you tell me what that was again?
Well, whether or not home care companies are providing PPE
Right.
at this moment.
Yeah, and I think that there's a little mix between both. I believe that it's been challenging to get them. So home care companies have been working on getting PPE, and they've been very creative, as home care companies often are, at how they're accessing them. But one of the ways has been through promotional items. Promotional vendors have been landing some PPE for us, but it's very expensive. And it's coming as a huge hit to the bottom line for home care companies, because right now they've taken a big dive and now they're spending money on PPE at a high premium. So it's been a really challenging piece. But I would say for the most part, home care companies are taking the hit on the price of PPE.
Gotcha. We also have another question from Beth Droppert. Can you address the issue of home care for demented patients and safety issues for both the client and the caregiver, since families cannot be as involved at this time? It's a good question.
It's a good question. It's a really challenging question, Beth. What we've heard across the board is that there's a decline for patients that have any kind of Alzheimer's, dementia. the isolation has been really challenging for people, and not being able to see them. And for instance, we're not able to go into communities. Some communities are starting to let us in, but there's been a big decline. So some of the things that people are doing are trying to reach out by phone, having phone conversations with clients. One of the sweet things that With a Little Help did was that, I don't mean that to be a plug, but it was a very sweet, one of our caregivers set up they wouldn't let us go see the client, so we set up a call with the client. So she said she was kind of nervous. She felt like she wasn't gonna be able to have that whole conversation for the half hour that was scheduled. An hour later, they got off the phone, and when they got off the phone, he hung up saying, "That was so nice to have an old friend check on me." And I think that that's a really big thing that we're, just maybe, I don't want to say dismissing, but don't underestimate the value of what that phone call can mean. Because there's so much that can happen in a phone call. Just feeling, I've been calling my aunts who are in communities, and she said it's really, boring and it's really depressing, she said. So shy of getting to talk to me or my cousins, she's not getting to talk to anybody. And it's really sad and boring, as she says. So I just am trying to encourage people, don't underestimate the value of that phone call.
Yeah, and I just wanted to unmute, hang on one second, Annie Jacobson, who is on the line. And she is, obviously she focuses on people with dementia. So Annie, do you want to jump in here?
Sure. Thank you. I didn't expect to be on video today.
Yeah.
So
Surprise.
hey, it's all good. It's all good. A couple of things that with the caregivers, when I was with home care assistants that I was doing, and with some of the families I've been coaching with, is really checking our emotions is one of the biggest things we need to do, because remembering that the logic, the reasoning, the understanding why somebody's doing something, that function can be reduced. But reading our intensity, reading our angst, the emotional registration is still there. And that's facial expression, that's tone of voice, that's pace of speaking, all of that. And there's this overlying stress right now. And the brain that is transitioning, changing with dementia is not processing the why. The pieces don't make sense. But the energy is there, and then it triggers the amygdala, our fight or flight, trying to keep us safe, and everything just gets ramped up. Mm-hmm. So figuring out where we can keep calm, where we can keep some levity, humor can be great. And even for people that aren't familiar with technology, one of the things I've really been working on is getting the video screen there, because the facial expression, mm-hmm. Seeing that, hearing the tone of voice with the eyes, more than just a phone call, even if they're not familiar with screen time. There's a family I'm coaching with who's in one of the Care Partners communities, and the husband and wife are trying to visit. She's got fairly severe dementia, and she's not figuring out the screen time. And with quarantine, they're trying to let him visit, but it doesn't go well. They played music together. He played guitar. So she wasn't connecting with a screen, I said, have you had Bill play any music for her? Oh, no, we really haven't. She doesn't like the screen. I said, listen, different part of the brain, different way to access, brings in that emotion, that historic connection, that emotive memory and joy. And it's a totally different part of the brain. Suddenly she was paying attention to the screen. Okay. So we need to think about doing things differently. And the biggest thing I've seen succeed right now is checking our emotion and thinking, how can we engage with that emotion part of their brain in a loving, peaceful, maybe even playful way. Mm-hmm. I hope that's helpful.
Yeah, that's great. Thanks for jumping in on that. I really appreciate it, Annie.
And I've been able to I'm always available on the phone. If there's a specific, this is what we're bumping into, mm-hmm. just brainstorming it, playing with it, give me a call. I'm super easy with that. And sometimes we've been trying it this way, and then we just need to come around this way and try it a little differently. And if I can help with that, I'm here.
That's great. Thanks, Annie
Thanks, Robin.
Jacobson. I really appreciate that.
Annie.
We have another question from Kyoko Kai Corbett, who said, I'm wondering if a high percentage of home care caregivers are getting COVID given the lack of PPE and their work requires proximity to people indoors. That's kind of a good question.
Well, it was interesting because of all the companies that were surveyed, only 90% said that they had not had a COVID positive client or caregiver.
So is that because there's such a decrease in the number of caregivers going into homes, and do you expect that to change? And that might even be a question for you, question for Dale, I don't know.
Yeah, I think it's a little bit of both because I mean, personally, I think home care is really one of the safest long-term care solutions right now. People are in their homes, they're not going out and being exposed. Caregivers, for the most part in home care, are going to particular homes. They're not always in communities, they're going into people's homes, so they're not as exposed.
Mhm.
So I think would you agree with that, Dale?
Yeah, I would.
Yeah, it's a really safe long-term solution right now.
Mm-hmm.
And I think companies are getting really creative, you know, from creating wellness packages so that they're just doing check-ins and making sure that the client's okay, and doing some of the grocery shopping. That's, you know, some of the things we're trying to do is just what can we do that's not going to be touching the client or coming in contact with the client. One of our caregivers took a ribbon that was 6 feet long and laid it between the client and her to show her, this is how far I'm going to stay away from you and this is why. And just, she said it was a great visual and the client appreciated the visual of that. Knowing how far away they really should stay to just keep each other safe. And what can they do without actually coming in contact? And there is a lot of things they can do, and a lot of conversations. I have a couple of sheets I'll attach here, but you know, it's just, there are questions. You can have different kinds of conversations. You can, and for those, some of them are not, they don't feel like they don't care. Some of our clients have been just, they don't care. They'll wear a mask, and our client caregiver will wear a mask, and they're okay to play a game with them.
Mm-hmm.
To still engage.
Yeah. And question from Maggie Pheasant. She's curious about what percentage of your clients are suffering from dementia and are cared for in their homes, and how are you reaching out to help the primary caregiver that since they often have no respite? Like what is the role of home care to support family members, friends, or others who are the primary, you know, caregiver?
Yeah, I wish I could give you that percentage, and I don't know it. I'd be happy to try to look into that for you, but I don't know that, Maggie. I will say respite is one of the biggest things that we do. It's an important piece of what we do, because that caregiver who's there nonstop, it's exhausting. And if they're not getting any kind of break, they're burning out. And their patients, as Annie was talking about, like their whole well-being becomes this kind of, and it gets really challenging. So I would say a majority of what we do is provide respite care.
Mm-hmm. And Steve Overman very rightly just reinforces that taking individuals outside has the double benefit of safety and mental health.
Right.
Yeah.
And that's one of the other ways where we understand that some of the communities are just now starting to let their clients go, or their residents go outside. So we're starting to figure out, like, how can we then just connect with them outside and take them for a walk? If we can't go in, what can we do on the outside? And I may have been somebody on this call actually told me that they met a client outside, and it was the first time they had been outside since February, which is so sad to me.
Yeah, incredible.
Yeah.
So for the advocates and family members who are thinking about having home care caregivers, do you have some suggested screening and questions given the situation with COVID that, you know, would be really helpful to make sure that are asked? How do we make sure that safety is kind of checking the box in terms
Right.
of hiring caregivers?
Well, it was interesting because I was having this conversation with my our client care services manager today, and one of the things she said, it's been really challenging. It's challenging before this, but now with COVID, it's been extra challenging because clients are requesting, can we only have one caregiver?
Mm-hmm.
Which can be slightly unrealistic in many situations because we want to have only one caregiver and we want her not to see anybody else. And so some companies have put into place, we're happy to do that if you're willing to provide 35 hours of, if we can provide up to 35 hours of care or a minimum hours of care that caregiver needs to make a living. Because she can't go in for 2 hours once a week only with you and not see any of her other clients. It's a real catch-22.
Mm-hmm.
So I mean, you can ask the question, but is it realistic that you're going to actually get that? I don't think so, probably.
But
Unless
probably
you're really
asking how many other clients that particular caregiver is exposed to.
Sure. When we had another client, I think one of the questions would be, has this caregiver been traveling? Is this caregiver working in other communities? And I think the community piece is pretty big. And some of the communities, if we have a caregiver that's working in another community, will not let that caregiver into their community.
Right.
Mm-hmm.
Right.
So Beth Droppert is just mentioned, I've heard of clients providing a living space for the caregiver so they can keep the same person.
Mm-hmm. That's true. And when we're doing live-ins, when we're doing 24/7 care anyways, it's required that you have a place for the caregiver to sleep. The caregiver needs to get up to 8 hours of sleep on those shifts. So they can be available, but they still need to have their own space.
Mm-hmm.
And I think that's really important as well, especially during this time. And it's not to mention that are they willing to wear a mask for however long you need them there?
Right. It's a long time.
It's a long time. And, I know even with our caregivers, we've given them a little bit of flexibility. So we said, if you've gone downstairs to put a load of laundry in, feel free to take your mask off and breathe. Are you in the kitchen and they're in another room? Can you take your mask off and breathe a little bit? It's a long time to wear, if you're on an 8-hour shift, to wear a mask.
Mm-hmm. And Annie Jacobson also mentions that many caregivers work for more than one agency.
Yeah, absolutely. Absolutely. And that's a really challenging piece of it as well. It's like, and some of them tell you and some of them don't, right?
That's exactly why I brought it up, Shawn.
Yeah.
We can do the best we can as a home care agency to vet and have them feel safe being honest with us about where they're working. Yet when families ask for that commitment, it can be tricky.
Right.
So any other tips or suggestions, Shawn, that you have in just having that dialogue?
Well, as far as what they should be asking for home care, yeah, I mean, I would ask if they do symptom checks. I think that's important. Are they doing symptom checks? And if so, if they have symptoms, what's the protocol? If the client has, that's the other piece. I mean, we want it to be safe both ways. That's why we've asked clients to do symptom checks as well. I think that's an important piece. Are they going into communities? Are they seeing other patients? If so, what's the exposure there? And the reality is, we don't really know. And our caregivers are not being tested, even though they're considered essential workers. They're not being tested unless they have symptoms and have gone to the doctor and gone through the process. And even if they were all to be tested, and I think Dell could speak to this, that really only suggests that they were not positive that day. So, right. So it's a risk. And there is that risk factor when you're having care in your home, and that's challenging, but it is a risk factor. I still think it's the safest risk factor, but it is a risk factor. And the reality is, if you need care, that need for care is not gone away, even if you stopped your services. And that's kind of what we're seeing. People may have stopped their services for 1 or 2 months, but they need the care. And so their health might be declining, or as Dell says, all the people that she's talking about, that Dell's talking about, that aren't going in because they have a stroke or they've had a heart attack or they are having those are the people we care for, right? So it's challenging right now, because for the same reasons that they're not going to the hospital, they're not having us in. And, you know, as far as I don't know of anybody, although somebody on our statewide walk-a call the other day did say that they were caring for COVID patients, but I asked them to please reach out to me and say who they were, so I would know. I said, I need somebody to refer to, because we've had requests. We've had very few requests, though, I will say, because really, if they're needing care and they have COVID, they're probably at the hospital or in skilled nursing right now.
Or they're not that sick, right?
Or they're not that sick that they need care, right?
So if you're really sick, go to the hospital, and then, you know, they may be limited, though, and they maybe could use additional help if they're not feeling well. But you know, I wanted to comment. I read something really recently that the national, I don't know the proper letters for the national, one of the national organizations of nursing homes have balked against planning ahead for this very kind of situation. So it clearly, I think, had a greater impact for home care than it would have needed to if they had been planning ahead. So not doing simulations, not necessarily having thoughtful plans for what if something hits. And there's actually a government regulation that says they're supposed to do that. But a lot of pushback, especially over the last 3 years, being allowed to kind of ignore some of the regulations that got passed from earlier infections and earlier issues. And I'm not talking about, you know, is your kitchen clean in the nursing home? It's really planning ahead, having a game plan for this very thing. And a number of the nursing homes were really blown away that this could be happening. And yet all of the public health people and even government regulations predicted it. Yeah.
So in moving, can I just ask a follow-up question in that vein, which is, okay, so now we're living with COVID-19 and we're going to be living with it for quite some time, looks like. So what can we be all doing to help nursing homes, assisted living, our homes, make sure that we're continuing to be safe and prioritizing the health of everyone? Because that's the big part of this whole virus, is it needs to take everyone, right?
It does, yeah. And it's changing our usual behaviors. I mean, if we don't want to have a really bad storm of COVID plus flu in the fall, we need to keep being careful. I just saw that as of today, King County is going to be applying to do a modified phase 1, sort of a, you know, 1.5 instead of phase 2. Yeah, and I know somebody had asked about contact tracing. I think it's better now that we can test people, but it's not as pervasive as what we would need to really launch into a much broader, you know, that's the phase 3, phase 4 side of things. But in the smaller counties, they've done really well, and that's partly why they've been able to open up. And there's now 26 out of 39 counties that are either in phase 2 or heading into phase 2. So it is really working. And just keep your fingers crossed that all these large gatherings don't kind of set us back. And I did want to correct, I looked at King County, we're at 557 deaths. And that's not a big jump from last week. I think it was 554. So that's really good. On the 17th of May, I look at different sources, so that's part of the deal. Sometimes the numbers don't all add up, but 17th of May was the last time that that the Washington University of Washington research group updated it, and our death rate was 9 per day there, and they actually were predicting still a decrease, sort of a slower decrease than what we'd hoped for. So I think we are doing better, and hopefully the governor will approve that modification, because it does open things up part way in a way that will be less feeling less claustrophobic, I think, for people, you know, not being able to physically go into a store. And, you know, I'd be happy to go in if I have to wait a little bit, you know, to my favorite small store, that kind of thing. So,
yeah. So Lisa Casaro asks 557. I think she's mentioning the deaths since when? Since when? That's King County, right?
That's King County, and those are all the COVID deaths total.
Since the beginning.
Yeah.
That we know of, which are likely undercounted.
Yeah, there probably are undercounted. The first death was in February. So we had that first case in January, but that individual survived. And then the first death was in early February. So that's the total. Yeah.
Great, thank you. And as we're wrapping up here, we just have a couple minutes left. I'd like to just hand it back over to Shawn to see if you have any remaining comments or suggestions as we're
Well, one other question I thought of while you were talking is that what is their intake process? So just to limit exposure right now, the guidelines have been adjusted so that we don't have to do in-person intakes. So that limits the exposure. So I would ask what their intake process is right now and how fast they can get care set up based on that. I think that's an important piece. And, you know, a lot of people are going through DocuSign or doing it online. It's just, we've done an intake that was with a video intake that they walked us around and showed us the house. And so some of that stuff is just limiting the exposure. And I think that's important to think about.
For going forward, why not do them that way, right? Yeah.
Right. And I think that that's one of the things we've been working with John Hilger on is just what is it that we're learning now that we could actually take away and still implement going forward so that we're limiting exposure all the time and making things more efficient so we're able to start care quicker. It's been really eye-opening from a home care standpoint. Wouldn't you agree with that, Annie? Is she still there?
She might be muted.
Absolutely. I've gone outside to weed while I'm listening. I'm sorry. I'm being honest, ladies. I'm being honest, everybody. Yes, I would absolutely agree. The ability to be inside a home with the video option, if the families don't know how to do that, it's even worth trying to talk them through and coach it, because the safety, the functionality, you learn so much from seeing the home and how to best support that family. In lieu of that option, there was one start of care that I did where they didn't do the video walkthrough, but I spent time with the caregiver ahead and said, you're going to be our eyes and ears. You're going to be such valuable information. And so they debriefed after, and we learned a few things, adjusted a few things, set up some stuff that we wouldn't have even thought of because I had never been able to be in the home. So there are ways to do it, but yeah, the relationship with the caregivers is vital if you're not going to be there, because they're going to be the ones that can see what's actually going on in there the first time.
Right. The other piece of that is the part that I love, and Julie and I were having a conversation about this the other day, that it's going to be a really great opportunity for more collaboration between the caregivers, the care manager, the advocate, and the home care company and the family members through these Zoom meetings. And I think that's going to be one of the big takeaways, is how we're able to be on the same page a lot quicker through doing Zoom meetings just like this. So it was great. We had 60 caregivers on a Zoom meeting, and it's changing the way we're communicating with a really remote workforce. And
I am finding the caregivers feeling an added value and investment, and they have stepped up to the challenge unbelievably.
Yep.
The people that are frontline doing the work have really shined during all this.
Yeah,
Well,
I'm going to share my screen just for a minute, Robin,
No.
if it's all right with you. I have a couple of things here.
we're right at time. So is that something that we're able to post to
Sure.
the?
Yeah, you bet.
Okay.
I have, hang on, now I have to do it in order to make it happen, to get out of it. Sorry.
Okay.
So this is some, what I've been calling garden art, and it's, can you see it?
No.
No.
Oh, well, apparently I can't get out of it now. I was just gonna say, it's been a great way to just connect and kind of find a little nature, is to do some garden art that has been, you just pick things up out of your yard and then make pictures out of it. And I think that those are some things that we can do that are simple and everybody can.
Well, I'd like to thank Shawn D'Amelio of With a Little Help and Dale Reisner for today's great conversation around caregiving and home care. And this is sponsored by the Washington State Health Advocacy Association. Join us next Monday when we're going to be talking about hospice during COVID-19 with speakers Stacy Jones, who's the director of Providence Hospice and Palliative Care, and Bruce Smith, who is a doctor and medical director at Providence Health and Services. So look forward to seeing you here again next week at 11 a.m. And if you've enjoyed this conversation, please fill out the survey that you'll be receiving today. We seek to provide you information to help you and your practice, and also help one another through this difficult time. Thank you to Andy Jacobson and everybody else who tuned in today. We'll see you again next week. Bye.
Thanks, everyone. Be well.
Yeah.